Let's invite Dr. Manpreet Kaur. She's going to take us through her experience initial experience with these capsulator.
Thank you, sir. So I'll be presenting on Capsulotomy my initial insight. At the outset, there are no financial disclosures. So continuous curvilinear capsulorhexis, we all know, is a prerequisite to achieve optimal outcomes. In fact, the transition to phaco was marked from going from manual capsulotomy to a continuous curvilinear capsulorhexis, and of late laser capsulotomies are in vogue. We have femtolaser, we have zepto, and now we have capsulaser. So what's the mechanism of action? The trypan blue stained capsule absorbs the orange wavelength laser energy, and the type 4 collagen of the capsule is converted to an amorphous collagen. So photocoagulation is the mechanism in this as compared to a photodisruptive laser as in femto. So this is just a case, one of the initial cases that we tried. So as per the company advice, we did stain with a trypan blue dye provided by them for a total of 1 minute. So after 30 seconds, you have to inject a small amount of BSS. It helps in more uniform staining. Air bubbles should ideally be avoided because they do interfere with the uniformity of staining. And make sure to wash the dye thoroughly because the orange laser is going to be absorbed by the dye. So you don't want any aberrant staining and you want a uniform capsular staining. OVD is then injected, and typically you should slightly overfill the OVD. After you have filled in, we usually use a 2.2 incision to inject the OVD, and then the paracentesis to inject slightly more so that there's a slight overfill, which will lead to a flattening of anterior capsule. So as flat and anterior capsule you have, the more uniform would be the laser application and less chances of tissue bridges. Centration is not pupil centric. You have to center on the Purkinje images. This fixation ring aids in centration, or the trypan blue landmark as is said. So the cross, as you can see, these two lights, we are so used to the laser system, you have to align all the lights. These have to be apart and the cross has to be there, which changes into an inverted V configuration when you place the fixation ring. And these two lights should not coincide. So it's a less than 0.3 second capsulotomy procedure. It's over in the blink of an eye when you press the foot pedal. You can alter the size of capsulotomy as well till up to 5.5 millimeters. So initial cases we did have a few tissue bridges, so I had a habit of going in with the tomy only to just release those bridges and then gently pull towards the center. This had minimal bridges. So once you gain experience, you can go in with, I prefer a tomy to release those adhesions. You can use a forceps or any other device. Subsequent phacoemulsification is uneventful. You can do a normal hydro procedure. So as in femto, whenever you used to make a capsulotomy, you know that hydro is not the same as it is in if you are doing a phacoemulsification, because the cortical rim is also cut with the capsule, so you cannot really go a clear cortical cleaving hydrodissection. Similarly, this also has a slightly different behavior than a normal phaco, but otherwise it does not interfere with pre-rotation of the nucleus or subsequent nucleotomy. So the capsule is of course resistant to all the normal phaco maneuvers. It's quite strong. Unless you have tags, that can be a potential source of weakness. So after that, we'll implant the IL. Sorry. Can I have the... Yeah. So I'm also removing some of the remnant cortical matter after implanting the IL. I'll be polishing the anterior capsular rim slightly, and you can see that these maneuvers have no adverse impact on the capsulotomy edge, so it was quite strong. So in a premium IL, this is a case of a premium IL, what you look for is ideal centration and ideal coverage, and both could be optimally achieved in this case. So you can see a well-centered IL with the Purkinje images right in the center and a perfect rhexis-tomy. So the customizable capsulotomy diameter ranges from 4 to 5.5 mm in 0.1 increments. So we aim for a 5 mm capsulotomy for 360-degree coverage of IL optic, so that 0.5 mm is left all around for a 6 mm conventional IL optic. significance, it helps in centration and prevention of PCO. So what I realized was when we did a 5 mm target capsulotomy, so when I put the images in Image, I found them to be smaller than my usual. So it was leading to a 4.08 mm capsulotomy diameter. So I increased it to 5.3. So what I ended up with in a 6 mm optics was 4.48. So maybe it has to do with the amount of OVD fill, some centration changes in hands, in different hands, but I preferred a larger capsulotomy to achieve the size that was my usual with a manual continuous curvilinear capsulorhexis. Then centration and focusing Purkinje images and trypan capsular landmark are used. So this is before the fixation ring is placed and with the fixation ring. So maybe since there is a variability in the amount of, there is a laxity that you can go from the cross to this, both are correct. So maybe this does impact capsulotomy size as well. Centration was perfect, as you can see in these post-operative images. Strength, of course, it has already been covered by Mr. David, that strong capsulotomy edge is resistant to tearing. Microadhesions of note are a potential point of weakness from where the tomy may extend. But as you can see in the case, they are highly resistant to polishing. So this is a case of intumescent white cataract. So this is where I really found an advantage of the capsule laser. So after a uniform staining, OVD fill, so what we have is a fluid release in these white cataract cases. So this is a fluid-filled liquefied cataract. As you can see, there is no burst of fluid that occurs or a sudden egress that we have faced even in flax. So there's a slow release of fluid going on. So this was really a very beautiful thing that I observed with capsule laser, that it's allowing a slow release of intralenticular pressure. And as you can see, now it's fluid filled. So I did go in with a tomy to see if there is any residual micro adhesion present. But the slow release of fluid is where this capsule laser is really beneficial. So as you can see, the capsulotomy was complete all around. So I was just using this tomy needle as a precaution in case any tissue bridges remain. So there were some micro adhesions, but no tags per se remained once I had removed them. So if you look at flax, there's a burst of fluid when the femto laser is applied. In contrast, capsule laser gave a beautiful, slow, sustained release, was over quickly. So this is one area in which I think it has a definite potential advantage. So in a case of intumescent cataract, it does fare better than all other methods. So coming to just summarizing my initial insight, anatomical parameters, circularity was perfect. Continuity, tissue bridges may be due to improper focusing, the initial learning curve, areas of fibrosis, scarring are easy to release. Centration is perfect, strength of the edge, it's stronger than CCC unless you have micro tags, etc., in which you extend. Size, in my experience, 5.3 to 5.5 mm for target 5 mm capsulotomy may be better. Ease and time, excellent ergonomics, fast, comparison with other laser capsulotomy. So flax now is advocated that it's basically good for capsulotomy, and for incisions and nucleotomy per se, the advantage may not outweigh. So in that case, a portable device that's attached to the microscope itself may incorporate all the advantages of laser systems without any potential extra cost or disadvantages. Cost effectiveness, of course, is there. It's a portable single-time laser system. Thank you for a patient hearing.
Thank you, Manpreet, for highlighting all these things. I think this is a device which may make the life simpler for our phacosurgeons, where you need to have a perfect central opening in the anterior capsule. As she summarized towards the end, again, I'll ask the question to all three of you. You have access to a femtosecond laser device and you have a capsule laser. Which one to prefer now? Adit? Capsule laser. Manpreet?
Both have their potential advantages and disadvantages, but capsule laser is a nice way to go. Yeah.
Okay. David has a different opinion.
Of course. So I think that definitely in complex cases it shines, and you can see the strength really
नहीं अभी पहले चल
So let's, some of them look right, some don't. So that will play out if you start looking at it.
Okay, I think we are getting late. Sorry, we can have a discussion.